Welcome to This Week in Hearing, our series we call The Giants of Audiology. I'm Bob Traynor, your host for this episode, coming to you live from the Tinnitus Enhancer Bar in Fort Collins, Colorado. Today, my guest is Dr. Jay Hall, an internationally known audiologist whose topic for this episode is titled Golden OAEs and Jewett Bumps in the Road. Thanks for being with us today, Jay, and we're really excited to have you here with us to talk about things. And I understand that you're quite a beer guy, and you brought some things with you, some actual beers from your area with you that you love, and I have some with me. And so if you show me yours, I'll show you mine.
That's a deal, Bob. More than happy to. Yeah, I do have, one good thing about Maine, I'm on the coast of Maine, is we have a lot of microbreweries throughout the state. Actually, you might be interested in knowing this, Bob. There are more microbreweries in Maine per capita than any other state except Colorado. So we have that in common. So this is an organic, not that I always seek it out, organic session beer. It's a summer session, which means it's derived from the British policies or tradition of the professor taking some of the students from the college to the pub to continue the to continue the class, and so they continue their session at the pub. And you had to have low alcohol beer to do that, obviously, to make it work. This is another great brewery, Baxter. It's about an hour away, and they brew their own seltzer as well as beer. My wife loves seltzer now, so we go up there and buy 2 or 3 cases and have it. And then one last prop here, and I don't know if you can top this one in terms of size, Bob, but this is, of course, a growler, and this is one of our favorite little microbreweries. It's way out in the woods. You got to go on a dirt road for about 5 miles to get to it, walk through the cow poop, but the beer is great. They've got a Scottish ale that's excellent.
Well, and of course, you've shown me yours. Now it's my turn. Now no Coloradoan would be worth their salt without a Coors in their hand. Of course, I remember the day as an assistant at University of Arkansas Medical Sciences where I brought a whole trunkload of this back at Christmas time just to serve to my friends. Here's one of our local ones that is a great German Pilsner. And the German Pilsner, this one's by a little brewery out of Loveland, Colorado called Prost. And but it's a super little Pilsner. But it's early here in Colorado, so I have to I won't be able to imbibe too much without having it be cut just a little bit. And so the Soul people make a chelada, which is tomato juice and beer. We've had those over the years as well.
Wow, interesting.
And, I'm not sure that this SOL means anything on the outside of the can, but here we go. Mm-hmm. So my understanding is that that it's not real easy for a new speech pathologist to come from Northwestern University to go to Baylor University and study audiology under the preeminent Dr. James Jerger. So I understand we were going to talk just a little bit about some of those first experiences with, the Jewett bumps in the road.
Absolutely, Bob. Well, I was at Northwestern University as a speech pathologist, but I was a closet audiologist at the time. Of course, that term wasn't commonly used because I really wanted to be an audiologist after taking in my first semester of the master's course, a wonderful intro to audiology course by Earl Harford, who, as you know, was one of Jim Jerger's colleagues, slightly younger, and also a Raymond Carhart student. By the way, Raymond Carhart was right there at the time, and he would come into the intro class or also special topics in audiology. I had a few electives, and I took that course. And he would come in, Tom Tillman, Doug Knopfsinger. I mean, if you didn't want to be an audiologist after listening to these guys talk, that just wasn't going to be your profession. So I knew I wanted to be an audiologist when I got my master's degree in speech pathology. And I talked to Deborah Hayes, who was a master's degree student in audiology at the same time that I was there. She said, well, I'm going to go to Baylor College of Medicine and study with Jim Jerger. And I started, of course, I knew who he was. And I said, I think I'll do that too. So I went down as a speech pathologist, and as luck would have it, shortly thereafter, about 6 months after I got there, Craig Dunkel, a lot of people know Craig, he quit the staff there to go into one of the very first private practices in Texas. It was in Dallas. So he moved up to Dallas. And that created an opening in audiology. And Jim Jerger came over to me. He knew already I wanted to be an audiologist. He said, how do you like to work in the audiology clinic in the morning? Because the speech pathology clinic wasn't all that busy. And I jumped at the opportunity and never looked back.
Cool. Well, and of course, now we all know you as a guy who's had 200 peer review publications, invited articles, book chapters, and even 11 books. And I would say that any audiologist that has not read one of your books from cover to cover now, and they are kind of thick, if I remember right, but if they haven't read that cover to cover, there it is.
If you, right by there. Thick, you mean 871 pages.
And of course, we've all read that from cover to cover, Jay. Audiologists worth their salt have all read your stuff, and we also know that not in addition to our relationship at the University of Florida, where we worked together for 20 years or so, you now hold part-time audiology positions at Salus University and the University of Hawaii, and then I hear you always have to tell your wife every once in a while that you hold a position that's titled Extraordinary Professor at the University of Pretoria in South Africa.
I'll tell you, Bob, whenever people introduce me, they always kind of somehow emphasize that extraordinary, word in that title. And my wife has been in the audience with those introductions. And I look at her and she rolls her eyes and says, he's as ordinary as can be. But the term, it's a wonderful term. It's, of course, in South Africa, there's a British influence, but also a Dutch influence. And so the term actually is a nice way of saying you're not getting paid. It's an adjunct position, but an unpaid adjunct. So that's extraordinary because most of the people there actually get paid. They're the ordinary ones.
Yeah, the idea is all of us that have taught courses at one time or another all thought that we were extraordinary professors anyway. So,
right. In our own mind, we were legends.
In our own mind, that's right.
Yeah.
Well, what kind of equipment were you even? What kind of equipment was around in 1973 when you began looking at these Jewett bumps in the road?
Well, Jim Jerger is known for many things. Obviously, diagnostic audiology and the cross-check principle. But many people don't realize that back in the 60s, now this is before the discovery of ABR, back in the 60s, Jim Jerger had this rack of equipment in the clinic, not in the lab, in the clinic, with switches and filters and sound producers, sound generators, and a little Nicolay oscilloscope, which was used for averaging cortical evoked responses. That's what he was doing. He stayed away from ECOG entirely because one of the faculty members in otolaryngology, Al Coates, who did a lot of work with ECOG and ENG, was the ECOG king there, guru. So Jim had this rack of equipment. So as the 1960s ended, Jim was good friends with Robert Galambos. So, Jim knew the ABR was coming along before anybody else, probably, except maybe a few other of Galambos's colleagues. So he modified this rack of equipment to do ABR. It was quite easy to do. You just change a few parameters. So by the time I got there, 1973, 2 years before Galambos' big studies and right around the time, a year or so after the Jewett and Williston paper in 70 and 71, we were doing ABRs. I say we, I was still a speech pathologist trying to get my C's in audiology. So I was kind of low on the totem pole, but I was well aware that this new electrophysiologic technique, it wasn't called ABR, it was called brainstem evoked potential or brainstem evoked response. But I knew that would be the next wave of diagnostic testing, at least in children.
Now, my understanding is you had kind of a unique assignment as kind of the lowest guy on the pole there to to conduct these BAERs as well.
Absolutely, that is true. I was spending actually the afternoons in speech pathology, my mornings in audiology, and then I finally had enough coursework in audiology, and I got my C's, and then I was a full-time audiologist. But still, I was low on the totem pole. Deborah Hayes was well on her way to being an expert in audiology. There were others, and of course, Dr. Turga was there. So I was basically functioning as an assistant, which was fine with me because I could learn the technique. So what we'd do, Bob, is we would see older children for ABRs right in the clinic. But even then, this was 1974, 75, kids would come in. I mean, the word got out. They were coming from all around the world, really, for ABRs. And some of them needed to be sedated. So we would roll this rack of equipment. That was one of my jobs. Roll the rack of equipment to an elevator, go up 2 floors in the neurosensory center there in Houston. And we go to the pediatric ambulatory surgery area. And some nurse, prior to us getting there, would sedate our patient. So we'd get up there in the morning, usually 8 or 9. It was very exciting. We all had well-starched, stiff, lab coats. We strode into that with masks on like we owned the place. And of course, nobody knew what the hell we were doing there, to be honest with you. And so I would do the assisting. I'd scrub the baby, and I'd, of course, roll the equipment up, and I'd handle any problems that might arise. If you want me to get into the nitty gritty, let me just tell you that some of these kids would wake up soon after they were supposed to be asleep and where you're testing them. And we'd draw the conclusion that maybe the sedation was not having an effect. Now, back then, Bob, the sedation was not oral syrup where you'd squirt it in the mouth. In the little babies, it was a suppository. And it basically looked like a little pill that was blue. We called them blue bullets.
Oh, the little blue pills.
The little blue pills would be pushed up where the sun don't shine, so to speak. And the baby, if they had a bowel movement, would eject this little blue pill. And that's when Larry Malden and Deborah Hayes and the rest of the crew would go for coffee and say, Jay, can you get that sedation back where it belongs? So I started at the bottom, so to speak, and I worked my way up.
Well, obviously the bottom is a great place to start because you learn so many extra kinds of things that you wouldn't necessarily know if you started in the middle or somewhere. But my understanding is you were one of the early investigators and developers of some of the newborn hearing screening specific procedures. And I know you worked with Marion Downs. And if our colleagues don't remember Marion, that's a void in your historical background in audiology. So go to Hearing in Children and find out. But I know you worked with Marion and the development of the newborn hearing screening programs. That's the standard almost all over the world now.
Absolutely, Bob. In my career, I've been around at the right time, the right place, to be involved in some exciting endeavors. And one of the most exciting really was in the early 1980s. Now, at the time, it seemed like I'd gotten my Ph.D. ages ago, but that was in 1979. I got my Ph.D. By 1980 and 81, I was performing ABRs on infants at University of Pennsylvania, where my first real job after my Ph.D. And newborn hearing screening was already being discussed. Galambos had shown it could be done. And then I took a position as director of audiology at the University of Texas Medical School in Houston. And the hospital there Herman Hospital had a big nursery, intensive care nursery, had 3 helicopters that would bring kids in. And I approached neonatology and I said, people around the country at teaching hospitals where their children are now screening the hearing of babies who are at risk. And I told them about Marion Downs, about the Joint Committee on Infant Hearing, which she basically started. Back then, there were 7 risk factors. And by 1982, the same year I got there, we had started a newborn screening program that was an at-risk program using the big Nicolay CA 1000. Now, interestingly, when I talked to my colleagues, Roger Ruth and Paul Kaleni, and many others around the country, they were all doing the same thing. Everybody was independently getting into this area. And that experience, starting that program, and I did it again at Vanderbilt, started a newborn hearing screening, first for the at-risk and later for the well babies. that got me to know Marion Downs really well, and Christy Yoshinagi Tano and others. And before you know it, Marion had arranged for all of us to go to Capitol Hill in Washington to meet with senators and congressmen to talk to them about the importance of early identification of hearing loss and early intervention. And as time went on, against all odds, thanks to Marion Downs as our leader, we then had universal newborn hearing screening. And of course, there was an NIH consensus conference in '93 that spurred that along. So it all started with my interest in ABR. And I think for any young people listening, the message here is when somebody knocks on the door, grab the door and open it up and just rush in. And even if you don't know everything you need to know, you can always wing it at the beginning. But what audiologists are capable of getting involved in all kinds of interesting endeavors if they just give it a try.
Yeah, Marion was one of my professors. I was just fortunate to be at the University of Colorado as an intern when she was active, and we learned how to go about doing pediatric hearing assessment from the mastress of pediatric hearing assessment, and when the ABR procedures came about, those of us that had gone through all of the hour-and-a-half, 2-hour sessions with kids now realized we could do it in a much shorter period of time, thanks to colleagues who have done some of the research and development of that area. Well, now in the newborn hearing screening area, what kind of equipment was used back in the early days?
Yeah, well, and I just want to point out they were early days, but boy, I'll tell you, things were happening fast. Yeah. I mean, here's the ABR being introduced as a tool for newborn screening by Robert Galambos in 1975, published a series of articles. And within 5 or 6 years, a lot of us, almost every major teaching hospital in the country was using ABR in the intensive care nursery for at-risk kids. And Deborah Hayes, Jerry Northern, a few others, Jack Roush, began to point out that of all the children who, say, enter school with hearing loss, only about half of them are at risk for hearing loss at birth. The rest of them are healthy babies. So that's what got a lot of people thinking, if we think newborn hearing screening is so important, we should be doing it in all babies, not just the at-risk. But to do that, we need to have some equipment that's not going to be used by an audiologist, that's automated, that could be used by a nurse or a technician. And so a quick story here. At this point, I was at the University of Texas, and I got a call from Aaron Thornton, who was a bright guy, Iowa grad at Mass Eye and Ear. And I'm from Connecticut, and I visited his clinic once on a trip back to Connecticut. He was in Boston when I was going to see my family, and he showed me this phenomenal template that he developed. It started with just transparencies, which he laid over ABRs of infants. And he began to show that if he traced the ABR of every infant onto a single transparency, and then he put all these transparencies up on an X-ray viewing box, there was a template. You could see all the ABRs kind of fit in the same pattern. And so he developed a very rudimentary computer program to detect ABRs. Well, a company out in Palo Alto picked up on that idea. Somehow the rights were sold to him. And the next thing you know, I'm winging my way to San Francisco, where I'm meeting, again, Paul Kaleni, Roger Ruth, Aaron Thornton, a bunch of big names, Mike Gorga. And we were shown this prototype totally automated ABR system called the Algo 1. And then they said, we need someone to conduct the clinical trials, to collect some clinical data. And I volunteered, so did Paul Kaleni. He was at Michigan. Roger Ruth was at University of Virginia. I'm in Texas. And we were selected as the 3 sites. And so this was the first automated ABR system in the world. And the later generations of that equipment are still being used today. And we conducted data only in the at-risk. We showed that this automated device did just as good a job as an expert in ABRs in terms of identifying an ABR when it was there, and most importantly, not seeing an ABR when it shouldn't have been there. So the false negatives and false positives were sufficiently low to justify its use as a clinical device. I'll tell you, Bob, that was so exciting because that was the linchpin for universal newborn hearing screening and all the early hearing detection and intervention programs that have developed since then.
And of course, now all the millions of children that have had
Millions around the world.
It's
Yep.
that was one of the main contributions to the profession from a group of very innovative colleagues, including yourself. Now, with ABR, where do you see the use of things like 40 hertz and middle latencies and cortical potentials, and where do you see that going? I know it's kind of there somewhat, but still a little on the researchy side for many people. Where do you see all that going? And I guess you could probably include the VIMPs in there as well. I'm sure that the group would like to hear what your perception of maybe that is where the newborn hearing screening was, 30 years ago. Who knows? So.
Yeah, that's a great question, Bob. And of course, I could wax on for hours about it. I've actually given some talks at an international evoke response international meeting. When I gave the talk was in Russia, but we've gone to meetings around the world on that very topic. When I look back at OAEs, oral emittance measures, certainly ABR, I try to assess what does it take to get a procedure from the laboratory or from a research procedure into routine clinical use. And there are several ingredients that are critical. One is you've got to have a device that's user-friendly. You've got to have normative data. But you've also have to have clinical data showing that this really is an advance. It's really going to do things better than whatever you're doing at the time. So clearly ABR was better than behavioral audiometry in infants and young children. OAEs were providing unique information, and oral emittance were. And you have to have somebody, and for oral emittance, it was certainly Jim Turger, who would have one foot in the lab and one foot in the clinic and say, okay, we're going to take this equipment, we're going to use it on thousands of people, and we're going to very simply describe a protocol and procedures for using it in the clinic. Well, that was done for ABR, OAEs, oral emittance, et cetera, but it's never really been done for the cortical responses. And it's ironic because they've been around since 1939. And as I mentioned at the outset, Jim Jerger and others were using them in the 60s before ABR. So what we need is we need a piece of equipment which would allow you or somebody who doesn't have a lot of experience with evoked responses to put the electrodes on the patient. That's easy. And to collect the data and either analyze it automatically or provide some guidance. And interestingly, Harvey Dillon in Australia at the NAL developed that very piece of equipment. But it's not been marketed well. It was picked up by a real ear measurement company as the company that would market it, and it's languishing. I don't think it's available. And everyone I've talked to would agree, if we had that type of equipment picked up by a major manufacturer and the price was right, people would start using it in auditory processing disorders. They'd be using it to confirm that the brain's developing appropriately with cochlear implants or with hearing aids in infants, because Anu Sharma and others have done the research. It's all there. So it really comes down to instrumentation. And an equipment company, it's a catch-22. The equipment company won't develop the equipment until they know there's a demand, but you'll never know there's a demand until you have the equipment. Yeah. And so that's where we're stuck right now.
Wow. Well, and that more likely than not is the future of the use of ABR at the various latency levels and so on for what we've found so far. Now, I recall that in 2007, the Colorado Rockies, believe it or not, the Rockies now were in the World Series with the Boston Red Sox, which I know is your team.
Yes, you'll see some memorabilia on my yes, and that reminds me, Bob. I don't know if this rings a bell here. If we can get a close up of that. But,
and if those of our colleagues who don't know this, Fat Tire at one time was a little Colorado brewery here in Fort Collins. It was made by a brewery here in Fort Collins called New Belgium, and they had a big bicycle as the logo and all that, and of course Jay and I had a bet that day that was going to be me for the Rockies. If I won, he would send me his favorite from Florida or Maine or East Coast someplace. And if he won, then I would send him my favorite from Colorado. Well, about the history is there, of course, where the Rockies lost and probably should have, but the beer went on, and that's where the glass came from. And I've always told Jay that it cost me more to send a case of beer to Florida than it did to buy the beer itself. So
those were
our stories.
Yeah, those were bottles, not cans, Bob, and they were what you'd call bombers. They were big bottles. And so that was a heavy box delivered. And then in the box, wrapped very carefully, were two of these glasses. One has not survived, but one did, with the fat tire emblem. It's been used, obviously, a lot.
Well, that's good.
That's when I learned, Bob, that you are a man of your word. You could have easily just blown it off and said, well, I can't ship it. It's too expensive. But you came through.
Well, we have to get more of those going. One of these days, the Rockies may blink and end up there another time. So, well, now while we're here, what actually got you involved in OAEs? I mean, OAEs were kind of like ABR and this and that, but how did you get involved with OAEs? I mean, here's a guy with 2-3 books on OAEs, and
they're right behind me.
Nice to know how you got started.
Well, just to set the time frame, it was the early 1990s. Now, OAEs had been discovered by David Kemp in the 1978. So, I mean, it was really early, just actually during the heyday of oral emittance studies.
But actually, you've even said that it was Thomas Golden, right?
Well, yeah, we go back to Thomas Gold. Thomas Gold, right, in 1948, which is a special year for me, actually reported on these active processes in the cochlea. And he was pretty much criticized roundly by everybody from von Vecchi down, because they said, no, the ear's incapable of that. All the tuning is going on in the nerves and the brain. It can't be the ear. But Thomas Gold was convinced the ear was producing energy based on his research in Cambridge, England, with animals. And he ended up going into astronomy, became a famous astrophysicist, and ended up at Cornell University. But David Kemp had known about this, and he started studying what led to the discovery of OEEs, cochlear physiology in mid-70s. But nobody knew about it unless you were a basic scientist. He published his article, Kemp did, in JASA, Journal of the Acoustical Society. So I literally had never heard of it until the mid-1980s. And I started hearing articles or listening to papers by Susan Norton and a few other clinical audiologists who were also researchers. And I talked to some basic science people who said, yeah, we're using these in the clinic more, studying animals. So I said to myself, if it's from the cochlea, if it actually reflects outer hair cell function, this may be the next ABR. This may be the next big electrophysiologic breakthrough. And so I started to study them. And I remember when Jim Jerger was retiring or leaving Baylor College of Medicine, or celebrating his 25th year there, I was invited to a wonderful event in Houston. It came from Nashville down to Houston to attend this, and everybody had to give a paper. So I said, geez, I'm going to be with a very, very high level group of people. I better come up with a topic that is novel. I'm not going to recycle some of my own old talks. So I studied about OAEs, and my title was something like, are OAEs going to be a clinically valuable technique, or something like that? Chuck Berlin was in the audience. He'd done quite a bit of work with OAEs. There were many others. And I basically said, these have great potential, even maybe for newborn hearing screening. Certainly they do in diagnosis of hearing loss. There was enough information out there. At this time, Kemp had just come out with his ILO 88 in 1988. And the more I read about him, the more I said, I've got to get a device to do this. And I put a little grant application in with a guy by the name of Tim Trine. Some people may know the name. He's at Starkey, very bright guy. At that time, he's a master's student. He wrote this little grant for local funds right there at Vanderbilt, a couple $1,000s to buy an OEE device. and we bought our ILO 88. And I did what Jim Jerger always did. He'd get a new device. And of course, this was before HIPAA was a real concern and the IRB. And we just started using this technique on every patient that walked through the door, whether they needed it or not. We wouldn't bill for it, but we just do it. I mean, we could do OAEs in a couple of minutes. So people, they didn't know what was going on. They just thought it was another test. And we started collecting data. That was Jim Jerger's strategy. Collect the data and see what you get. And I pretty much realized, you're going to discover some kids with profound hearing loss who have normal OAEs. That's how we discovered auditory neuropathy. You're going to have some patients of any age who have what appears to be hearing loss. Really, it's either psychogenic, or it's malingering, or it's a false hearing loss, but you'll find that out. And you're going to detect cochlear deficits in people with normal audiograms, whether they have tinnitus or noise-induced hearing loss, ototoxicity. We realized instantly, within a year or two, that this device and this technique was going to provide information you couldn't get any other way. So from then on, I said, okay, now I know this is going to be big. I want to write the first book on it, or at least one of the early books, and I'll call it a handbook. And because when you use this technique, you're going to have data on hundreds of patients, and you can illustrate anything you want about this new technique. And I'm still really on a crusade to get people to use OAEs the way they should diagnostically in most patients, adults or children.
Well, particularly DP OAEs have taken over a lot of the OAE kind of evaluations. As working with the 3M earplug cases, and I have been as well, and many of our colleagues have done this. It's DP OAEs are huge in looking for hidden hearing loss and some of the other areas that are beyond the traditional hearing evaluation.
And they're objective, Bob. So you brought up litigation. That brings up the issue of, is this a real problem or is it a false problem? Could the person somehow be making everyone think they have a problem, but they really don't? Well, OAEs are totally objective. As I say, objective tests don't lie. Always trust the objective test. And you're right. So OAEs, we're not even scratching the surface. Or when I say we, clinical audiology, in terms of the clinical application of OAEs. It's frustrating. Most people use it as a simple little screening tool and don't get the full diagnostic value out of it.
Well, one of the areas when you and I started team teaching, one of the courses, the actual counseling course at Florida, one of your areas was always tinnitus. And I know you've been into tinnitus for a very long time. I hear some dog tinnitus going on.
I wondered if that dog was taking issue with something I just said about OAEs.
No, I'm sure she has some tinnitus, and that's got to do some sound therapy on her. But anyway, the deal is that you've been involved in tinnitus for a long time. How did you get involved in tinnitus and doing some of the research in that area?
It's in some respects the same story that I've been relating since we started talking. I took advantage of an opportunity. Back in the mid-1990s, I had been to England and I'd met a wonderful, wonderful guy, David Bagley, who sadly just died a couple of months ago, within the last month.
Too early, for sure.
Much too early. Oh, it's a shock. I'm still trying to recover from it. And David and I hit it off right away. He's about 10 years younger than me. And we went to pubs in Cambridge where he was. And then I said, if you're ever in the United States, you got to come to Vanderbilt and visit our clinic. And my wife and I will host you at our house. And he did. And it cemented our friendship. Well, David came in. Of course, you got to give the customary talk, when you visit a clinic. And I promoted it, and we had a huge crowd. And David talked about audiologists assessing and managing hyperacusis and bothersome tinnitus. And I told David just bluntly that I said, when I hear a patient's got tinnitus and the patient's out in the waiting room, I try to run out the back door and give the patient to somebody else. I don't know what the heck to do with these patients. Tell them not to drink coffee, maybe, or something like that. And
that was the mode at that time, Jay.
Absolutely. It was you wanted to avoid these patients if you could, because you couldn't help them. And obviously they had needs. Well, at the end of David's talk, he looked me in the eye in front of the whole audience and he said, Jay, At a place like this, Vanderbilt University Medical Center, you have to have a tinnitus and hyperacusis clinic. You're the last resort. People expect you to be the expert on this topic, and they are desperate. And that, with that motivation, I took a Pavel Jastroboff course. Me and Roger Ruth, a few other people, John Jacobson, went the same time. It was in Baltimore, and it's a 3-day intensive workshop. And you come out of there knowing quite a bit about tinnitus. And then I did a lot of reading, and we opened a tinnitus and hyperacusis center at the Vanderbilt University. It was one of the first in the country in 1997. Well, one of my, around that time, the local newspaper health reporter called and said, we want to do a story about hearing aids. We understand Bill Clinton just got some in-the-ear hearing aids, and we think that, this would be a really popular story with the readership. And I said, well, I hate to tell you this, but I'm not a hearing aid expert. And to be honest with you, we haven't seen any change in our hearing aid business since Bill Clinton got the hearing aids. And the writer said, darn, anything else new happening there? I got to get a story ready for tomorrow. And I looked up on a bookshelf as I was talking to this person on the phone, and I see this loose leaf binder from this Jastroboff course. I said, well, about a month ago, I went to this course on tinnitus. It's really bothersome to some people. And we've started seeing patients, and they really seem to be helped. He said, you think you can get a patient of yours to be interviewed by me? And he came to the clinic the next day, wrote a story about tinnitus and tinnitus management, tinnitus retraining therapy, ran it in the paper. That was in about October. By the end of that morning that the paper, our article came out, we were booked with clinic tinnitus patients till the next March. Wow. Solid. The front desk people were ready to throttle me, kill me, because they were just answering. The phone was literally ringing off the wall. And so I realized, well, obviously this is a big deal. And that's where I started to shift much of my clinical and research attention and continuing education efforts to get audiologists up to speed on tinnitus. One of my theories, Bob, and one of my themes when I lecture is every audiologist should be capable of providing basic primary type care services to patients with bothersome tinnitus. You don't have to be a tinnitus expert. And if you do that, you will differentiate your practice. You're going to generate a lot of revenue, but most importantly, you're going to help a whole new population of patients.
That's kind of the way things go, though. And I think tinnitus was kind of on the back burner for a lot of clinics for a long time. But then, as there were more clinics and more competition and more competitive kind of interactive stuff to obtain patients for your clinic, then people started saying hearing loss and tinnitus in the title of their clinics, and we've seen that has gone almost like wildfire as well, because there's so many patients that do experience tinnitus.
You're entirely right, Bob. Yeah, I for one of my Salus University courses or advanced study certificate program in tinnitus, I have a course entitled How to Develop a Tinnitus Clinic. And I asked the students to do just what you suggested, just Google their area and the word tinnitus management. Now, the downside is that some of the people that are providing tinnitus services really don't have any background in that area. So it's clearly a marketing technique. But the bottom line is most areas now do have a tinnitus center. My theory, though, is if you're an audiologist, you had your own practice, a relatively small town in Colorado, you can counsel the patient, you can offer them suggestions on management, you can suggest enriching the sound environment, perhaps the use of melatonin. You can do all of that, and 80 to 85% of the patients will go away happy, and they'll not need anything else. So it's a golden opportunity for audiologists to snatch that market.
One of the other things that I think that we should bring up here, Jay, is you'll remember a couple of years ago, you and I did a little piece for Carl Strom over at Hearing Review, and in my clinic, I had been doing a basic evaluation that was similar to a basic evaluation that you had been discussing for a long time, where we did air conduction, we did admittance, we did DPOAEs, and we were doing speech and noise testing as our basic battery.
Right.
And we brought that up and presented that to the group and found that there were some people who really didn't think that was a good idea.
Yeah, and it really surprised me, and I think it surprised you because this is the way I was brought up with Jim Jerger. You did whatever you needed to do based on the patient's chief complaint to diagnose that patient properly, correctly. You didn't do what the insurance companies wanted you to do. You didn't do what the physician, neurolaryngologist said you had time to do. You provided whatever assessment you need. You don't have to use OEs on every patient or speech and noise. But if a patient comes into your clinic complaining of problems hearing speech and noise, I would say you have failed to evaluate them if you're just, for example, using word recognition and quiet. And if the person's got any risk for tinnitus or for cochlear loss or tinnitus, such as diabetes or noise exposure or potentially ototoxic drugs and many other number of risk factors, then you're obligated to use OAEs. You have no choice. Otherwise, you're not getting at the location in their auditory system where the problem is likely to be. So I just, I'm not going to tell somebody you should do it this way, but I've never done it this way. This is the way I practice audiology. It's the way you've practiced audiology. Yeah. It works. You get reimbursed, and most importantly, you're doing right by your patients.
Well, I think you can even add extended high frequency audiometry.
Oh, absolutely.
As well, because that combined with the OAEs is a huge factor in many cases, and
it's predictive of speech problems and noise too. It turns out. Yep.
Well, to kind of wrap things up here a little bit, Jay. I'm not going to pour any more beers or anything like that. We've already.
I'm not even going to pour one. It's just barely noon here in Maine.
Yeah, well, it's not even close here. So I think to wrap things up a little bit, what do you see in your crystal ball for the future of our profession? I think the profession has a huge future, although we'll be doing a lot of things differently than we are currently. And I guess the audience would be very interested to see what your perspective on the future of the profession would be.
Bob, you have an advantage, and we both have this perspective of 40 years. You've seen a lot, and you've seen challenges before, and you as a professional audiologist met those challenges. I think the future of audiology is very, very bright, and it's just ours for the grasping. But we've got to adapt and change the way we do things. You hear a lot about disruptive technology and disruptive changes in healthcare. Those are great because they offer an opportunity to expand and to get into new areas. So I'm going to just state a handful of ingredients that I think audiologists need to latch on to assure that their future is bright. The first is you can't put your future in selling hearing aids. That's part of the process, but we provide valuable services aside from the products. We've talked about tinnitus. We've talked about diagnosing hearing loss in infants. We didn't get into auditory processing disorders, diagnosis and management, but that's another area. We talked a little bit about VEMP and vestibular. These are areas that there's no other profession that can handle these things. If you encompass those valuable services and include hearing aids as part of the process, both for tinnitus and for managing hearing loss or cochlear implants, you're going to have all the patients you need. So that's one ingredient. The other is we've got to utilize automated technology whenever we have the opportunity. That means automated OAEs, automated admittance measurements. I mean, there are devices where as soon as the probe makes a seal, you get a temp, it runs a reflex. You don't need an audiologist doing that. We'll get to that. That brings up the third ingredient. But then the other automated is the automated audiometer. And Bob Margolis, as you know, developed a wonderful system called the AMTAS, marketed by GSI. And he and I recently did some interviews where, I was already convinced that automated audiometry should be in every audiology clinic. And if you'd say that to an audiologist, they'll say, well, I can't bill for it. I said, well, hell, don't bill for it. Don't even bother trying to bill for it. It's not being done by you. Focus on the services that only an audiologist can provide. So I'd want automation. And then the other ingredient is support staff. And I talked about OAEs, tympanometry, automated audiometry. An audiologist doesn't need to spend an hour doing that with a patient. We need assistants, audiology assistants, and audiology technicians who expand and extend our services, who can allow us to triple or quadruple the number of patients we see and reduce our overall costs. Dentists do it, optometrists do it, physicians do it. Why the heck aren't we doing it? So I think that with the right mindset, with an open mind, taking advantage of opportunities that come along, like we've discussed in this last hour or so, the future is incredibly bright.
My sentiments exactly, and I know that we have a limited time with you today, and I certainly, on behalf of This Week in Hearing and my audiology colleagues out in our audience who may not have had the opportunity to kind of slightly get to know Jay just a little bit better. And again, so thanks for being my guest on This Week in Hearing, and also for your contribution as being one of the giants of audiology.
It's been my pleasure, Bob. Thank you so much.